Okay. So ankle ultrasound, posterior and lateral part. So we will talk in four divisions. One is anatomy, sonoanatomy, pathology, and video section. In anatomy part, many things were told last day also. So few things are common. But anyway, when I'm saying the anatomy, it is from say deep to superficial. So most deepest structure is bone and joints. Bone joints, synovial sac, capsule, these are deepest structure, and that is covered by ligaments. So just above the bone, we will search for ligaments, bone to bone ligaments. And then comes muscle and tendon. Nerves and vessels will be there. Above that, we will talk about that. And then retinaculum. Retinaculum is most superficial. Every retinaculum is not clearly seen, every part, but then few retinaculum is seen. And then bursa. Bursa is again deep superficial. Bursa do not maintain a specific depth. It is found everywhere. So then bursa is mainly always seen between a tendon and bone. This is the common area for bursa. Then skin and subcutaneous tissue, it is there. So, okay. So here, as we talk about ankle joint, it is mainly the joint between tibia, fibula, and talus. Tibia, fibula, and talus. Beyond that, it will become foot. We will talk about those things in foot class. So here we know that talus has the joint formation with both tibia and fibula. So this is the articular surface for fibula, and this is articular surface for tibia. If we see from front above or from above, yeah. Then if we see from below, then you can see that this is posterior calcaneal surface and another surface is from with the navicular. So front side, it attaches, this talus bone attaches to the navicular, and below towards the heel, it attaches to the calcaneum. So this much is in the bone part. Then we know that synovial sac. So this is covered by capsule. So this forms joint recesses. So tibiopatellar joint recess. This is the actual, when we say ankle joint effusion, there can be effusion at many areas, but this tibiopatellar joint actually meant when we say that ankle joint effusion. So tibiopatellar joint, anterior joint recess or posterior joint recess, these areas are joint recesses where we should search for effusion. Okay, then these anterior joint recess and posterior joint recess, sometimes it is connected and sometimes not connected with subtalar joint space. Okay, so these three areas are the areas for searching if there is a effusion in patient. If there is a small amount of effusion, then these three areas are the areas for searching that whether effusion is there or not. Then comes ligament. So ligaments, as I told you, bone to bone connection is ligament. It is at that depth you have to search. So ligament, as we talked about the medial ligaments. So medial ligaments were deltoid ligaments. We know that from tibia to all the bones. Okay, tibia to talus, tibia to calcaneum, tibia to spring, and tibia to navicular. So these are these are medial sided ligaments. So you don't have to remember the names, because just you remember the bones. So you know that from it will always start from tibia. So for to all the bones, one is only the spring ligament. Okay, two spring ligaments. So these four parts make the deltoid ligament. Okay, then comes laterally. So laterally, these ligaments starts from fibula. Just as with the medial ligament, deltoid ligament starts with tibia. In laterally, all the ligaments start with from the fibula. So there are only two bones. Either it is fibula to talus, that is talofibular ligament, or it is towards the calcaneum, fibulocalcaneum or calcaneofibular ligament. Okay. Now ATFL injury, it is very common injury. So that means anterior talofibular ligament, this one. this talofibular ligament can be posterior also, but that is hardly any importance. We cannot see well. So this is the ATFL is the most important ligament, means fibula to talus. Okay, so this ligament is very much prone to injury. Then this one was told last day only, anterior tibiofibular ligament. Okay, so why I'm just saying, because while examining the talofibular, if we start from tibiofibular, then this finding talofibular becomes a bit easier. Okay, so just remember, from front anterior side it is only tibiofibular, and from lateral side only two ligaments. Okay, two bones. That's why fibula to talus, fibula to calcaneum, and this talofibular can be anterior and posterior. Okay. Now comes muscle. So muscle and tendons. Now, this is important, but you don't have to remember. Okay, so think that these muscles these are at the cuff level. At the cuff level, this section has been done. So this is right side and this is left side. One person is standing, and at the cuff level, the section you are seeing, axial section. So this middle part is medial side, and both this side lateral, this side lateral. Okay, so now if we think that this side, this middle portion is the medial for both the legs, right leg and left leg, then at this area, at this calf area, there are three compartments. We can, if we think in this way, section wise, so then there are three compartments. One is anterior compartment, one is lateral compartment, one is posterior compartment. But posterior compartment is divided in two parts. One is superficial posterior compartment, one is deep posterior compartment. So at the cuff level, with these two bones, it forms three compartments. We think in that way, that it forms three compartments. But when it comes to the ankle level, then what happens? There are four compartments: medial, lateral, anterior, and posterior. Then what happens? Then lateral compartment remains lateral, anterior compartment remains anterior, but posterior compartment, deep posterior compartment, becomes medial compartment, but superficial posterior compartment remains posterior. Okay, so posterior side, what are the muscles? There are only two muscles, that is gastrocnemius and soleus, nothing else. Of course, between them, this medial gastrocnemius, this is medial gastrocnemius. So between medial gastrocnemius and soleus, there is one tendon, very thin, plantaris tendon. Plantaris tendon. So these all make the Achilles tendon. So this is the posterior compartment, and this side medial compartment. So these deep muscles, they form the medial compartment. Anterior compartment you know already, and this is the peroneus longus and brevis. Remember, in lateral compartment, now brevis muscle, brevis, B for bone, B for brevis. This brevis muscle, whenever we will search with the ultrasound, we will see that which muscle or which tendon is with the bone, running with the bone. Which is running with the bone, that is brevis, and other one is longus. Okay. In ankle area, actually longus becomes tendon early, and brevis gradually becomes a tendon. But brevis takes the area which is just adjacent to the bone. Okay, so these are compartments. Now, this part already Dr. Devjyoti talked with you. This is the medial side. So three tendons start from medial malleolus. That is Tom, Dick, Harry. Okay. So this side, it is the tibialis posterior. Dick means this is the flexor digitorum longus. Dick for digitorum. And Harry means hallux. So, hallucis. So flexor hallucis longus, Tom, Dick, Harry. And when we see the anterior side, it will be Tom, Harry, Dick. So from medial malleolus, tibialis anterior, Harry means hallucis. So this is extensor compartment. So extensor hallucis longus. Then Dick means digitorum. So extensor digitorum longus. So just for your remembering, this we read in our MBBS. Medial side always start from medial malleolus, Tom, Dick, Harry, and here Tom, Harry, Dick. Okay. Now comes posterior compartment and lateral compartment. So lateral compartment, there is nothing much to remember, only the peroneus longus and peroneus brevis. And posterior compartment, as we know, that soleus and gastrostomachus, these two main muscles, they are forming the they are forming the Achilles tendon. So that we will see in the posterior side. Of course, there is one more tendon here, this flexor hallucis longus. This flexor hallucis longus, when we are seeing posteriorly in this area, Achilles tendon, soleus, gastrostomachus, then this tendon is also seen. Flexor hallucis longus is also seen. So we have to understand that, okay, this is not the part of posterior compartment. This is going in the medial side, and we are just by seeing by ultrasound, we can see this. Okay. So now it is the bursa. It is the bursa in which we are interested. So different bursas are there. This is the subcutaneous in posterior side. Retrocalcaneal bursa is a very important bursa. We can see the retrocalcaneal bursa, but there can be a bursitis. Here you can see in this picture. In this picture, you can see it is a superficial bursa. It is not under the Achilles tendon. It is above the Achilles tendon. So that is called subcutaneous calcaneal bursa. That is subcutaneous. Actually, sometimes it is written supracalcaneal bursa, supracalcaneal or calcaneal bursa, and retrocalcaneal bursa is always under the calcaneum. Okay, retrocalcaneal bursa. Now, subcutaneous, some other subcutaneous bursas are also there that can be over the lateral malleolus or over the even medial malleolus. So these are called premalleolar bursa. Okay, so nothing much, only some subcutaneous bursas, and important is supracalcaneal, retrocalcaneal bursa, which is a very important important bursa for bursitis reason. Now comes retinaculum. Now, remember the retinaculum in this way, that superior extensor retinaculum, just a minute. Now, remember in this way that ultimately this front side is the extensor side. Okay, this is the extensor side. So whatever retinaculum is there, that is the that is ultimately extensor retinaculum. So extensor retinaculum can be superior or inferior. Okay, so this part is superior extensor retinaculum. It will be like this. Okay, it will be like this from tibia to fibula, and the inferior extensor retinaculum, it will be like a cross. Okay, this cross has, then name has been given, 4 names has been given to all the 4 parts. So this is the superomedial area, and then this is the superolateral area, that is inferomedial, and inferolateral area has been given another name, that is frondiform ligament. So just remember that in front, this is the you, if you draw it like that, then you will draw in this way, that this straight line is the superior extensor retinaculum, and lower one, X, is inferior extensor retinaculum. Now, after these retinaculums, there are 2 other parts. That is, when we go laterally, there is one superficial peroneal retinaculum that starts from fibula and goes to the calcaneum or Achilles tendon. So this part, this is the third retinaculum, superficial peroneal retinaculum, and 4th one is flexor retinaculum. Okay, so though different books have a bit different, sometimes they give connection with this one. Okay, there is connection, but then I found that this much only is sufficient. So 2 retinaculums are there in the front, and each side one retinaculum. One is peroneal retinaculum in the lateral side, one is flexor retinaculum in the medial side. nerve. So we know, those who are from anesthesia, they all know that for ankle block, we need to block five nerves. Okay, so what are the nerves? Nerves are ultimately they are coming from three. There has to be branches from three nerves only. One is femoral nerve, and other is uh, posterior tibial or and peroneal. These three nerves only. No other nerves are there. So ultimately, in the front side there is only one nerve, that is the deep peroneal nerve or anterior tibial nerve. Same. Both the names are there in books, but they are same. So deep peroneal nerve or anterior tibial nerve, it is in the front side. A bit in the lateral side, superficial peroneal nerve will be there, and another nerve is there that is called sural nerve. This is the sural nerve. And uh, medial side, there are two nerves. So one is saphenous nerve and one is posterior tibial nerve. So posterior tibial or tibial you can say, but anyway, posterior tibial nerve. So uh, medial side two nerves, lateral side two nerves, and in the front one nerve. Total five nerves. Okay, so laterally when talking, we will show you. I will show you the laterally sural nerve, and of course, superficial peroneal nerve, last day also you saw. So we can show again. So, so this is the sural nerve, how it is formed. So it is formed by the medial, both the common, it has part of common peroneal and tibial. Both parts are there to form the sural nerve. So you can see which area is affected. This, if you develop a sural nerve neuropathy. Common cause of sural nerve neuropathy, at least what I have seen in my practice also, it is due to the sural nerve biopsy. The if you do 10 biopsy, then one patient will have some ongoing symptoms. Sural nerve may not like it. So some tingling numbness in the sural nerve distribution, it is possible. Any small neuropathy, we go for hydrodissection. If it is not for a nerve ablation. This nerves we cannot go for nerve ablation. So artery. So artery is not important here. Only to show you just that anterior tibial becomes the dorsalis pedis. So anterior tibial, posterior tibial, they are only forming the plantar arches. Anyway, now I shall to show you the sonoanatomy part. Though I can demonstrate directly, but just few parts. Okay, sonoanatomy. So what is important here? Mainly the small areas we need this holistic probe or high frequency probe. High frequency probe sometimes with a smaller footprint. Footprint is better. But otherwise, we can go for linear probe also. Most, if it is in the posterior side, linear probe is must. Okay, there you cannot see by high frequency holistic probe, but in lateral side, sometimes high frequency holistic probe is more important. Okay, here, so this position, this is for posterior, examining the posterior side of the ankle, and this is for examining the lateral side of the ankle. Now, sometimes while seeing the lateral side, some people have, even in our volunteer also, there is a deep gap under the lateral malleolus. If patient is not of course, my patient volunteer is fat, but still there is a big gap. Then how will you do it? Then you put a lot of gel there, and that we call gel standoff technique. So in this type of uneven surfaces, we use gel standoff technique. Gel standoff technique is used for two purposes. One is for if it is the uneven surface, and second one, if we are doing a procedure which is too superficial, just under the skin or something, then you do not cannot use a big probe, because it doesn't give you the area of putting the needle. Okay, then we go for this gel standoff technique. So you can see this is a okay, this part we can show lateral. I will show you directly during the demonstration. It is better. So let us go for demonstration. Anyone has any question regarding the anatomy part? Otherwise, just let me make everything ready for demonstration. Today, actually, my internet connection is causing some issue. So, yeah. Yes. Good job. এটাকে একটু নরম করলে ভালো ছিল। Happen. Okay, I think you can see my screen, isn't it? Okay, you can see my screen and okay. Good. Oh, so first I will see. Ah, okay, so you can see the screen, isn't it? Sure. Disclosing decision. Hmm. Okay. Just a minute. Okay, you all can hear me clearly?
Yes.
Okay. It is causing so much trouble. Okay. Mm. Okay. Okay. So first structure, what I will show you is the Achilles tendon. From the posterior side, I am starting from the posterior side. So you can see the this one also, your PPT also, it shows. So here I can see the Achilles tendon. Okay. So this part, can you say what is this?
Calcaneum.
Yes, calcaneum. This is the Achilles tendon. Hmm. This part is nothing but the Kaget's fat pad. Okay, this is Kaget's fat pad. Do you remember the name of fat pad in the knee area?
Hofar's
Hoff's fat pad. Yes.
fat.
Yes. So this is Kaget's fat pad. Here my hand is coming in view, no? So I can keep it in the opposite side. So maybe this one is okay. So let us see. So we can see this is the your Achilles tendon. Remember this area mostly affected by tendinitis. When there is a hypoechoic area, then we will say it is a case of tendinitis. Of course, in a tendinitis case, patient presents with a acute condition, acute pain. Okay. If it is a tendinosis, then mostly it is in this area. Okay. In this area, or say 1 centimeter proximal from the insertion, not exactly at the insertion. So tendinosis and tendinitis, there is a difference, at least in presentation also. Tendinosis will be degenerative condition, and so it is a chronic case. Patient will have a subacute or chronic presentation. and not too severe. When patient, I mean, in acute case, the presentation will be much more severe, and there can be neovascularization also. So gradually I will go there where up to where there is the myotendinous junction and soleus muscle starts. In that area, actually sports injury can occur. Most of the time sports injury is commonly occurring at that area. Now here, as I told you, these parts are all fat, Kaget's fat pad. Can we see something below? So what is this? What is this area? What is this? Can anybody understand what is this?
The flexor hallucis longus.
Yes, this is flexor hallucis longus. So if I move the this one, if I move the tendon, you will be able to see the movement of this tendon. Yes. So this is the flexor hallucis longus. Okay. Sometimes it becomes a bit difficult for many to understand that what is seen there. So this is flexor hallucis. This is not a part of your posterior compartment. This is just we are seeing from the medial compartment. So now focus on the Achilles tendon. Achilles tendon is very thick here. Okay. As soon as soleus will start, it will become a bit thinner. Okay. So this thinning is normal. So soleus has started. Okay. So from here, there also in this area also there is a area for injury. This is a myotendinous junction. In sports injury, this area is I mean prone to injury. Okay. So this is soleus started. So we understood soleus has started, and this one is Achilles tendon. Now we will go more proximally, but towards say medial side. We will go towards medial side. So I think everyone has seen clearly that where the soleus is starting. So soleus has started, Achilles has become a bit thinner, a bit thinner. Now, when gastrocnemius will start, it will become even thinner. So these are the, when you go inside the soleus, there are some areas where you can see vessels. Soleus has big vessels, and that is normal. These are the vessels. Okay, these are not any uh, these are not any tear or rupture. These are the vessels in the soleus. Okay, so this is common. So this is you should know that this is common finding. Okay, so now I am going more proximally, and at some area we can see another muscle is starting. Another muscle. Actually, so this one is soleus, this one. So here in this area, another muscle has started. So this area, another muscle, it is a bipinnate muscle. So this area, another muscle has started. So this is the nothing but the gastrocnemius. This is the gastrocnemius muscle. This is the gastrocnemius muscle. This lower one was soleus, and the upper one is gastrocnemius. Okay. So this one I have already shown. Now, if you want to see the short axis, so I think this part everyone has understood, isn't it? Okay, so this is not there. So, so this part everyone has understood that Achilles tendon at different areas, different injury can occur. Now, let us see the short axis. Short axis also starts from the bone, calcaneum. Okay, so this is the calcaneum in short axis. It's a really problem. I think you are not seeing this camera. Just a minute. You notice me. Sorry, because my internet connection is causing too much trouble today. Just a minute. Anyway, so I could do this much only because it is really today there is a problem with the internet. So this much. Okay. Hmm. Okay. So here I will show you in short axis. Okay. So you can see that this is the bone, this is the calcaneum bone. Then I am gradually going proximally, so we can see clearly that this is the area of Achilles tendon. Can you see clearly that this is the Achilles tendon? Now, as I go more proximally, so below that, whatever you are seeing, that is the Kager's fat pad, because in below the between the bone and Achilles tendon, these are the Kager's fat pad. Okay. So as I am going down, you will gradually see one muscle will start. And that muscle is soleus. That muscle is now one muscle has started. Okay. So this is the soleus muscle. Now you can see that this is the soleus muscle. Okay. So clearly when you find this area, you also know that, okay, in this area, if we search in this way, then we will be able to see that how soleus starts. So this is the area when soleus has started. Now I will go a bit more proximally I am going, and you will see, so I will remain a bit medial sided so that I can see that gastrocnemius above. Gastrocnemius will come above. So where it should come? It should come in this area, So this is the gastrocnemius muscle. Okay. So this lower one, this part is soleus and this is the gastrocnemius. Okay. So what is these in between? These are two aponeurosis. One is gastrocnemius aponeurosis, and below that this is the soleus aponeurosis. Okay. There are two aponeurosis between soleus and gastrocnemius. Okay. Now question comes, so this is the area. Okay. Already I have shown you in long axis. Now question comes that somebody may want to see that where is the plantaris. So plantaris, as you understand, that plantaris is tendon in this area. Okay, plantaris is so plantaris, how it starts? It starts from the knee area, posterior lateral side. It is starting from the lateral side, and then it is coming medially. And going and joining with the Achilles tendon. Medially, we find it under the medial gastrocnemius. So the location is between medial gastrocnemius and soleus. Okay. So here, let us see what we are seeing here. The medial gastrocnemius we are seeing, and soleus we are seeing. So between these, so how to search this tendon? This tendon is actually here is the tendon. How do I know that this is the tendon? So remember, these two lines, which are the aponeurosis, it becomes three lines at one point. So in this area, if we see in a long axis also, this will become three lines. Again, these areas will be in two lines. Okay. So if I go down, then you will see that this part, this is the tendon. Okay. So this part, then it is a bit separate. You can see it is a bit separate. And it is going and joining with the Achilles tendon. So this is the plantaris tendon. In long axis also you can see actually. You can see now it is the three lines, this area. This sometimes it is a bit difficult, but if you go above and see, so this is the area of three lines. I can show you in long axis also. So this is the area of three lines. So this is the area where, so this is the in between. So these fibers are actually plantaris tendon. Others are, lower one is the aponeurosis of soleus, upper one is aponeurosis of gastrocnemius. If these three lines are, these areas are actually for plantaris tendon. Okay, plantaris we can bring it here. This is the plantaris muscle. Okay. No. not this one. Wait, I can show you also. So just above the, so just above the vessel, you can see the plantaris muscle also. So this is the plantaris muscle. This is the above the popliteal vessel. This muscle is the plantaris muscle. Okay. So I have put one video also. So this is the popliteus muscle. This is the popliteus muscle, and this is the tendon. What we are saying. So this is the tendon. This is the short tendon. This is the short tendon. It goes ultimately joins with the. So ultimately it is entering within the aponeurosis. You can see it is entering within the aponeurosis. Okay. So this is the posterior side, nothing more than that. Uh, anyone have any issue? Anything? Anyone have any question in the posterior side? I am audible, no, clearly?
Yes, sir.
Okay. So this is the posterior side. We will go with the lateral side now. Hey, Vijay,
Sir,
Shuja.
can you show us retrocalcaneal bursa?
Retrocalcaneal bursa. Okay, I will show you. Just a minute. Let us start from the lateral side now. I have some videos. I will show you from the video. হুম, হুম। না, তুই মানুষটা ঘোর। হুম, Okay. So this is the lateral side. We will go with the lateral side. So here, the main important thing in lateral side is ATFL ligament. Remember, I told you that if we start from tibiofibular, then it becomes very easy to find the talofibular also. So here, if when I just hold the ultrasound probe in a short axis manner, then what I can see, these are two bones. One is tibia, one is fibula. Lateral side, left side of your screen is the fibular side. Okay, that is the lateral side. Left side of your screen is fibula, and right side is tibia. Okay, so if I go down, then at one point, if I go straight, then at one point it is the tibia which vanishes, and then talus comes. So straight away, if between tibia and fibula, so between tibia and fibula, I am seeing the anterior tibiofibular ligament. If I decrease the depth a bit, so this is the anterior tibiofibular ligament. Okay, so this with my machine this much only, because this frequency is not very high. So this is the area. This is the area for tibiofibular. This is the tibiofibular ligament. This is the tibiofibular ligament, and the anterior tibiofibular ligament. Now I will be showing you the ATFL. So what I will do, one side will remain on the fibula. The opposite side I will just fistel to see the talus bone. So as soon as I see the talus bone, I know that I have already reached the area of talofibular ligament. Now I will just stretch. With Mm. So this is the anterior talofibular ligament. Actually, we need very high frequency for these ligaments. Tibiofibular, this is the tibiofibular, and this is the talofibular. I think. So this is the talofibular. So this ligament is the talofibular ligament. You match with the picture. So this is tibiofibular ligament, and I am showing you in the next page. So this is the talofibular ligament. Okay. So this ligament is the talofibular ligament. This one. We can go for some dynamic examination to see this. As soon as I do this movement, then talofibular ligament becomes a bit stretched. So this is the talofibular ligament. Okay. You can see this talofibular ligament. Yeah. I can put it here. Okay. So this is the talofibular ligament. Okay. If I move, then it is getting stretched. Sometimes it is a bit hyperechoic, sometimes it is hypoechoic. Okay. So this is talofibular ligament. So here the main thing is that one side fibula I know, and another side it has to be the talus. Okay. If I go up, then it is the tibiofibular ligament. Here, of course, the tibiofibular ligament is also not very clear because of the ultrasound probe is not of that high frequency. But this one is this area is the tibiofibular ligament, and then when I come down, this is the talofibular ligament area. Okay. Yeah, this frequency is not that good. Anyway, so this is the talofibular ligament. Okay. Now let us see the two other. So calcaneofibular ligament, I will show a bit later. Let us show you the peroneal tendons. Okay, peroneal tendons I will show you. So here you see, okay, I will show from here only. As I told you that there are two compartments. One is anterior compartment, one is peroneal compartment. Okay, so between the anterior and peroneal compartment, last day also we showed the common peroneal nerve, superficial peroneal nerve. Okay, so this is when we are on the tibia and fibula. Lateral side it is the fibula, and medial side it is the tibia. So when we go up like this, so between anterior and between tibia and fibula, this is the anterior compartment. My arrow is on the anterior compartment. Okay, and this side when I go laterally to the fibula, then this is the peroneal compartment. This is the peroneal compartment. So as I'm going down, you can see one thing, that in this area also, above the fibula, there is a tendon. This is a tendon. Okay, so this is a tendon. So what is this tendon? This tendon is nothing but the peroneus longus. Peroneus longus tendon. As I go down, then okay. So as I go down, then you can see another tendon is getting formed just around the fibula. So now it is formed. So this is the this now my arrow is on brevis tendon. Okay. So this is the brevis tendon. So brevis is always with the bone. Brevis is always with the bone. If I go proximally, you will be able to see this brevis is becoming muscle. But longus is tendon for a long time. Okay, longus is already a tendon at when I go proximally then also. But this one is brevis muscle. This lower one, this one is brevis muscle. So gradually when I go down more distally, then it has also become the tendon. So here I can see this is the remaining part of the muscle, and this is the tendon, brevis tendon, and this is the peroneus longus tendon. So when I'm going down, I can see both the tendons. Okay. So here in this area, So in this area, peroneus longus and brevis is there. So if someone has tendinitis, you will be able to see a lot of fluid around these tendons. Okay. Okay. So these are the brevis and longus. Now in these tendons, we can see in a long axis. How we will see? So this is, we can see in this type of, in this way, in long axis. Remember here also we are seeing both the two naras. So these are the tendons moving together, but these tendons, okay, so there is no fluid here, there is no fluid around. Here there are two tendons, one is superficial and one is deep. Always with the bone, it is the brevis tendon. Okay, there are two tendons, but then since there is no fluid, you cannot see any fluid and it looks like that both are together, but it is actually two tendon and there is a difference. I mean, there is a sheet between them. So here there is the gap between these two tendons. But when we see if there is a tendinitis and if we see in a long axis, then there is a lot of fluid around the tendons. So we have to check both in short axis and long axis. Okay. So this is the tendon. So now this tendon comes in this way. The under the lateral malleolus, it stays under the lateral malleolus, and then we can see these tendons in a both short axis and long axis view. So let me show you the tendon, this peroneal tendon as an inframalleolar view. So here I have put a lot of gel. So this is called gel standoff technique. So here you can see, otherwise we will not be able to see. So here you can see the tendons. So these are two tendons. Okay. So you can understand the upper one, this one was longus and this one is brevis. So these are the two tendons. These are inframalleolar view of the tendons. This is one tendon, this is another tendon. So I have crossed the malleolus here. Okay. So here in this area, you can see calcaneofibular ligament also. So this is the, so why I did not show you the calcaneofibular ligament is because when we see the peroneus longus brevis tendon in short axis, then it becomes a bit easier to search these ligaments. So this is the calcaneofibular ligament. This is the calcaneofibula. Though I am saying it partially, so this is the calcaneofibular ligament and this is the short axis of peroneus longus and brevis. Okay. This is, if I move like this, then this tendon also gets stretched. If calcaneum heel movement is there, if I move the heel, stretch the heel, then these ligaments also can be seen. So this is the area for calcaneofibular ligament. Yes, this one. So this one is the calcaneofibular ligament. Okay. So any other thing? So peroneal tendon, short axis, lateral malleolus you have seen. Inframalleolar view also I have shown you, and sural nerve. Okay, nerves. So sural nerve. So remember sural nerve, where I can show you the sural nerve here. So in lateral side, we have understood there are two nerves in the lateral side. One is sural nerve, one is superficial peroneal nerve. Superficial peroneal nerve already you have seen yesterday. I mean last day. Between these two, this is the superficial peroneal nerve. Okay, between these two compartments. So this is superficial peroneal nerve, and when I talk about sural nerve, then there is one important way that this is the Achilles tendon. Okay, let us see the Achilles tendon in a bit short axis manner, and then I will see the Achilles tendon from I will see that Achilles in a short axis from this side, and also the lateral malleolus. So when I'm seeing both the Achilles and this is the short axis. So this is the short axis of Achilles tendon. Okay, this is the short axis of Achilles tendon, and this is the lateral malleolus. This is the lateral malleolus. This is the lateral malleolus, and these are the your peroneus longus brevis. Peroneus longus brevis. These are the lateral malleolus. This is the lateral malleolus, and this is the Achilles tendon. So here, what I want to see, I want to see one vein. Here there is not. It is not the artery. It is the vein which is important. So what is the vein here? The vein is very prominent and big. Here. So these veins name is short saphenous vein. So here, what is that? This one is the short saphenous vein. So as soon as you see the short saphenous vein, you just try to, so this is the short saphenous vein, okay? So just beside the short saphenous vein, you try to look for the sural nerve. So this is the short saphenous vein, and this is the sural nerve. This is the sural nerve, okay? Just try to see that this has some honeycomb appearance. This has a small honeycomb appearance, okay? Now you can see that this has a honeycomb appearance. So this is the sural nerve, okay? So this is the technique, just lateral malleolus, and in short axis we are seeing the Achilles tendon. Immediately we will see the sural nerve, and after beside the sural nerve we will search for the nerve. So this is the nerve, this is the sural nerve, okay? So what is left? Superficial peroneal nerve I have shown. So okay, nothing more. Under ultrasound area, this much only. Anyone wants to see anything again? Any confusion? Any confusion? Anyone wants to see anything again? Otherwise, I will go with the pathology part. Okay then. If you don't want.
Can we see the medial side?
Medial side. So what you want to see?
Sir, the tubercle, talar tubercles, medial and lateral tubercle and the sustentaculum tali.
Sustentaculum tali. দেখি এরকম কর। হ্যাঁ হ্যাঁ শুয়ে যা। So sustentaculum tali is part of which bone?
Calcaneum.
হ্যাঁ which one?
Calcaneum.
Calcaneum, yes. Name is tali, but part of calcaneum. It becomes sometimes it is a bit difficult to understand that area, but otherwise for our uh, for a pain physician, our purpose is to see the FHL mainly, flexor hallucis longus. So this is the medial side. You can see all the tendons. So Tom, Dick, Harry. So you can see this one is the Tom, tibialis posterior, tibialis posterior. Okay, this one I will increase the gain a bit. Okay, so Tom. Then comes digitorum, flexor digitorum longus. Tom, Dick. Then comes Harry. So where is the Harry? Flexor hallucis longus. This one. This one is the flexor hallucis longus. If we go up, then we will see this flexor hallucis longus have muscle bulk associated. Okay, this have muscle bulk associated. But then if we go up, so this is a big muscle. This part is muscle actually. This part is muscle. As I come down, then we see that there is no. This is not muscle anymore. Tendon. This has become tendon. So can you see the talar tubercles? So in this area, if I go a bit up, so anterior talar tubercle, posterior talar tubercle, between that, this is the flexor hallucis longus, FHL. This is the FHL. This is the FHL. And here it is the calcaneum. As I come down, you can see there is another bone. So this is the calcaneum bone. This is the calcaneum. This is the calcaneum. So when I come down in this area, so this is the sustentaculum tali. This area is the sustentaculum tali. Here, this is the tendon. This is the tendon. This is the sustentaculum tali. You can see that there is a continuation from here to here. There is a continuation. So you see the movement. So when I'm seeing the talus more, then I'm seeing the sustentaculum tali. If I see in this area more, then I will see the when I'm moving in this way, then I'm seeing the sustentaculum tali, which is the calcaneal part. But when I'm doing like this, then I'm seeing the anterior and posterior talar tubercle. So that is part of talus. Okay. So you understood this one, and this one. Nothing more than that. This one, and this one, and this is the FHL. This is the FHL. Okay. And as I'm coming a bit down, so I'm seeing this is the sustentaculum tali. This is the sustentaculum tali, and this one is the FHL. Understood? Or any confusion there?
Yes, sir. Yes, sir. Got it, sir.
So this is just, I mean, just moving. You are when I'm doing like this, I'm seeing calcaneum. I'm just seeing like this. I'm seeing more of a talus part. That's it. Nothing else. Okay. So I think no other thing. Okay. Just few slides about the pathology part. Okay, so few slides about the pathology. Okay, so mainly in the posterior side, say Achilles tendinitis, tendinopathy, rupture, retrocalcaneal bursitis, ankle joint arthritis. So these are the areas we can see. And I mean, main pathologies related to the pain, and then ATFL is also very much important, and neuropathy. So as I told you, sural nerve neuropathy can occur. Virtually all types of neuropathy can occur. Tarsal tunnel syndrome also can occur. All say anterior tibial nerve also. Those who use the very tight shoelaces, they can have entrapment neuropathy of they can have entrapment neuropathy of anterior tibial nerve also. So virtually all types of neuropathy is possible. Now other type of bursitis. So as I showed you already, premalleolar bursitis is also possible. So as I told you, here this area is for acute presentation, which is insertional tendinitis, which is this enthesitis. So this is the insertional tendinitis area. If there is a fusiform swelling in this area, then you know it is a tendinosis. Okay, then if it is at the soleus and tendon junction, then you know it is most likely, I mean everything is not 100%, but most likely it is a sports related injury. Then it can be a area of even in the gastrocnemius muscle fibers also, from where the gastrocnemia starts. As it is the soleus starting and there can be an injury, it can be at the gastrocnemia starting area also. Achilles tendinitis. So you can see that there can be calcification. There can be calcification. There can be fluid around the Achilles tendon. So these things are possible, and so this is this some fluid is there. and this is the calcification is there. So there can be a case of Achilles tendinitis. Even in short axis, you can see fluid around the Achilles tendon. Achilles tendinosis, as I told you, there is a fusiform swelling. So this is a swelling, Achilles tendinosis. And not only swelling, when you see by cross section, you see it becomes a hypoechoic pattern. This is the normal structure. This is normal, which is fibrillar, bristles like fibrillar, and hyperechoic. Hyperechoic fibrillar is normal. Uh, uh, how we should see Achilles tendon in short axis, but then it has become hypoechoic, and this is also hypoechoic fusiform swelling. Okay, so this is a rupture. This is a clean rupture. So this is the fibrillar structure. It was going up to this much, and then it is not there. So there is a clean rupture. So rupture will not come to us usually. So this is the area for retrocalcaneal bursitis. This is the below the Achilles tendon, retrocalcaneal bursitis effusion. This is very common, comes to us, and so this is retrocalcaneal bursitis. Tennis leg, as I told you, that this is of course from where the gastrosnemius is starting. This is soleus, this is gastrosnemius. So gastrosnemius is starting here. So these are the fibers, muscle fibers. Okay, these fibers they are splitted from here. So this is a muscle fiber injury, not the complete tear of the gastrosnemius, but this is the muscle fiber injury. Anterior, this one was earlier last day's class. Dr. Devjyoti already has shown. So effusion can be tibiotalar joint, anterior tibiotalar recess. Just I showed you. So this is the effusion. This is the lot of effusion is there. Okay. So in posteriorly also tibiotalar joint, here it is the normal structure. If there is effusion, then this area will be filled by the effusion. I mean fluid. There will be hypoechoic signal from there. Subtalar joint also, this I forgot to show you, but then I can show you later also. No, but so tell us, this is the subtalar joint area. This is the subtalar joint area. So here also you can see that if there is small amount of effusion, but of course, if there is effusion in the tibiotalar joint, then you must see this area, and most of the time it is always present here, anterior tibiotalar recess. So this is subtalar joint. Peroneal tendonitis, as I told you, there is lot of effusion around the peroneal tendon. So this one means which tendon? One
Brevis. No, it's
brevis, yes, bone with bone. So always it is brevis, and it is the two is the longest. And if you do some put some colored Doppler, then if it is an acute presentation, then you will be seeing the signals, a lot of vascular signals. Okay, peroneal
Sir,
tendinopathy.
is that
Yes, tell
the
me.
previous slide? Is that tendinitis or tenosynovitis?
Tendinitis, yeah, tendinitis. Tenosynovitis and tendinitis, both are associated. I mean, whenever there is a tendinitis, then synovium also will be inflamed. Yeah, tenosynovitis also you can say, but tendinitis also you can say. This is ultimately inflammation, acute presentation inflammation. And tendinosis, most of the time it is degenerative. Okay, so here also there is some effusion is there, small effusion. Otherwise, if there is no effusion, no signal, patient's presentation is not acute, and it is just hypoechoic, then we say that it is probably the tendinosis. Tendinopathy, of course, by word, it includes everything. Tendinosis also, tendinitis also. It is an umbrella term. Okay. So here peroneus longus brevis we can see, and it is a actually swelling of tendon is there. If swelling is there, then most likely it is a tendinosis. Okay, so this is peroneus longus. Again, as I told you that we just now we saw the long axis of peroneus longus brevis, but we did not see any effusion. So it looked like that it is together one tendon. But when it is fluid is there, you will be able to see a lot of fluid between the tendons. And in short axis also, it will look like this. Remember, seeing peroneus longus and brevis in long axis, it is like it is hidden under the lateral malleolus. So your probe should be like you are hooking something. So then only you can see. Ligament injury, remember while playing badminton or tennis, we get this type of injuries. So how you I mean length falling of your foot, that will determine which side will go, which side injury you will have. So if it is it falls like this, then you understand that lateral side will have the injury, and if you fall like this, then medial side will have the injury. In medial side, it is the deltoid ligament. Deltoid ligament has different parts, of course, but then anyone, actually, deltoid ligament tear, anyone can go. But ATFL is more common. In lateral side, it is calcaneofibular or ATFL, anterior talofibular. So remember, ATFL is much more common than any other injury, any other ligament injury of the ankle. So this is lateral side. And so as we showed that ATFL, see, this is the ATFL normal structure, fibula and okay, this is not anterior talofibular ligament. It doesn't look like talofibular. It is tibiofibular, actually. This is tibiofibular. It is not talus. Anyway, so here it is talofibular ligament, and this is no. This is both are tibiofibular. Actually, it is wrongly written. Anyway, so tibia and fibula. There it is the I mean, it is not the normal ligament. This is the normal ligament, and this is not the normal ligament. So there is a ligament injury. Calcaneofibular, of course, injury is very rare, but still you can find some calcaneofibular ligament injury also. So this is the calcaneofibular ligament. This is the calcaneofibular ligament. Injury is not very evident here, but still tendinosis is possible. Calcaneofibular tendinosis. So there is some hypoechoic area, maybe some amount of swelling is also there. So these ligaments are mostly when examined clinically also, then we come to the diagnosis much more easily. So here these are the nerves: tip peroneal nerve, superficial nerve, peroneal nerve, all 5 nerves, as I told you. So they all can have entrapment neuropathy. Bursitis, these are premalleolar bursitis, both side, lateral side, medial side, any side it can occur, and in the posterior side also. Posterior side also, this bursitis can occur. So these are premalleolar bursitis when we can see. Okay, but if it is it can have the retrocalcaneal bursitis also, then we will not have this swelling. Okay. So this is the retrocalcaneal bursitis. This is the retrocalcaneal bursitis, and Achilles tendinitis. So in Achilles tendinitis also, already I have told, but precalcaneal or supracalcaneal bursitis or supracalcaneal bursitis. In that case, you can see this fluid will be seen here above the calcaneal, above the Achilles tendon. Okay, this is the above the Achilles tendon. Ganglion sometimes we see, and this is also not directly related to pain, but of course ganglion has a very I mean good success rate if we give a steroid injection, and sometimes ganglion can cause neural entrapment and neuropathic pain like picture. Not every time, but mainly in wrist area, due to ganglion, it can have median nerve neuropathy picture. Okay. So video section, we do not have a lot of video of this thing, but it is just the anterior side. So while going into the, it is in a short axis, it is held in a short axis. It is actually tibiotalar joint. So you can put your needle from both the side, actually, from lateral side also, from medial side also. You have to under ultrasound, you have to be very careful that you don't puncture the dorsalis pedis or anterior tibial artery. Okay, and then so these are not needed. Okay, so this one patient came to me. So this is Achilles tendinosis. Okay, so you see big swelling. This is a big swelling. Okay, so these fusiform swelling is also there, but then this area insertional tendinopathy, will say. So acute changes are also there. So it is not only a chronic case. So acute part is also there. here. So acute part is also there, and what we can see, so see in this area, small amount of effusion. So that is the retrocalcaneal bursitis effusion. In normal human being, this is not there, no fluid is there. Here, small amount of fluid. So this is the retrocalcaneal bursitis, and this is the fusiform swelling. This is the insertional area hypoechoic signal, and this is also a calcaneal spar, small calcaneal spar. So these four findings are there, and so this is a Achilles tendon, insertional tendinopathy. Okay. Okay. So did I? Okay, I show you the injection. No, 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 no. Okay, procedure is not there. Procedure also I did. You please check the YouTube videos. In YouTube, I have posted all the videos. There are a lot of videos. So in this Achilles tendon and insertional tendinopathy and injection, even the intervention part, already I have in YouTube. Okay, and ATFL I don't have. So in ankle part, only this one I have. Yeah. Okay then. Any question?
Can I ask something?
Yeah, please, please.
For the tendinosis and the acute together, you prefer doing PRP or
Oh, no, see, it is all about the, just a minute. Okay, so as I mean, the steroid or PRP, this is what you are saying, no? So I will say that this depends on the presentation. If it is a acute presentation, go for steroid, and if it is a chronic presentation, go for PRP. Okay, and
even in the case of Achilles tendon?
yeah, if of course in the Achilles tendon also, but not inside the tendon. Steroid you cannot give inside the tendon.
Yeah, that's
Okay,
right.
not within the fiber. It is peritendinous, always peritendinous.
Okay.
So, but of course, if it is a chronic case and going on and on for with a small pain, then we will not use this one, your at all. Steroid we will not use. But if it is a acute case, then only we will give peritendinous steroid. Okay.
Okay.
And those areas which are hypoechoic area, there you go for percutaneous tenotomy. You puncture for at least 20-25 time, because we want to bleed there. Their bleeding
Mhm.
should, and again inflammation starts and healing occurs. So you please see my YouTube video. You will
Yeah.
see the treatment also.
Okay, thank you.
Okay then. Good night. I think if you will put the questions, and if you have any question later, you tell me. Okay. Sorry for my internet connection today. It causes too much problem. Anyway, thank you. Thank you. Sir. Yeah. Good night.